I just want to say it's an honor to be here. Really wonderful. I feel very blessed. You all have been wonderful. I've enjoyed my time, and I've only been here 24 hours. So thank you for having me. I'm going to talk about robotic sacrocolpopexy. I just want to help maybe give some tips and some tricks about about the procedure itself. So again, I have no financial disclosures and a rough outline of what we're going to talk about. Talking about our selection of patients, our surgical considerations, evaluations, and then some efficiencies that I found throughout my experience. And then we're going to hint on postoperative care. So we know that abdominal sacrocolpopexy really is a wonderful treatment for pelvic organ prolapse. It's basically entirely done laparoscopic by our gynecology colleagues, robotically in urology. And we used to do it open, very morbid. We've really transitioned to the robotic approach. And I consider it the Cadillac of prolapse procedures. Now, interestingly enough, we've looked at the follow-up and the long-term outcomes, and we can see that there are some significant issues potentially. So this recent publication, well, it wasn't so recent, in 2013, highlighted that there's a mesh erosion rate up to 10%. Well, in the United States, we don't like that very much. And so really what ended up happening is people became very risk-averse, avoidant of the sacrocolpopexy procedure. That being said, literature has shown that maybe we had more complications initially, but the FDA is reporting that we have less now. We're maybe doing the procedure better, and we're maybe more efficient, and we've counseled our patients a little better. So it was hard to get patients to do mesh for a while, but now we're back doing some sacrocolpopexies. So what about patient selection? Obviously, you're not going to really offer this procedure unless you have apical prolapse. The top of the vagina is coming down. If you have anterior or just posterior prolapse, this is not the procedure to consider. What other things do I consider? Well, if the prolapse doesn't bother the patient, I'm not going to offer this to them because it is a morbid procedure potentially. You have to talk to your patient about sexual activity. If they're not interested in a vaginal reconstruction, I may offer them something like a colpocliesis or a colpectomy or just narrowing of the vagina. So really, that's most of the patient selection limitations. People say, what about older patients? Do you offer it? Absolutely. So literature shows it still works very well for a motivated patient. And so another thing that we find maybe more so in the States is obesity. And I have tried to do sacrocolpopexies on larger women. It sometimes is not so fun, especially for my residents. So really, I've started to have more of a cutoff around a body mass index of about 40. And this is because you have the sacral promontory. There's a lot of obesity there. And so trying to dig down to get on the sacrum when you have so much fat can be really disorienting. The other thing that you may want to consider is really starting with your sacral dissection. So even a patient that isn't obese, they may have odd anatomy that makes it challenging to do the case. So I start with the thing that's going to hinder me the most, and that's usually the sacral dissection. Now, I want to point out to all the oncologists in the room, prolapse is not cancer. So ultimately, you do have the option not to do the case. And having an alternative way of approaching the prolapse is probably the most important aspect. And I did this a couple of weeks ago. We did a lovely vaginal repair on someone I just couldn't dissect down to the anterior longitudinal ligament. So what other considerations? Well, we have to talk about the uterus, the ovaries, the fallopian tubes. You want to know, does this patient want the complete procedure, meaning you may have to go vaginally to do the repair? And then, of course, occult stress incontinence, which I think the room knows. We basically pull up that prolapse, and then we can increase their risk of incontinence. So that's an important conversation to have with patients. So we used to always do a supracervical hysterectomy, meaning remove the uterus, leave the cervix, and then do the robotic sacrocolpopexy. Our patients really are wanting to preserve their uterus, which really requires us urologists in the States to think outside of the box a little bit. So it's incredibly important for our patients to determine, do they want to keep the uterus or not? And that's not always a conversation we spend a lot of time on before. Now, salpingectomy is an aspect that I think we as urologists don't think about that much, but in gyne-OB world, they think about this all the time. So when you go in and get a tubal ligation, they're actually removing your fallopian tubes. So why don't we do the same thing? And the reason is that we think that a lot of ovarian cancers start in the fallopian tubes. We know that if we remove the fallopian tubes, you're not going to increase the risk of complications. You're not going to affect the ovarian function. And really, there are no increased risks of complications. So that's something you should think about when you do a supracervical hysterectomy, is removing the fallopian tubes. And that's always a conversation that we have. Now, more and more, we're starting to identify that prolapse recurs when we don't fix the perineum or the perineal body and the posterior vagina. That is one of the predisposing factors for our patients to come back in and be unhappy with prolapse recurrence. Well, it's hard to do this, right? If you're doing an abdominal procedure and then you have to go vaginally, you're swapping out your instruments, you're changing the entire course of the surgery and adding on a lot of time. So it's something you really need to think about. The good news for us is that most of the literature shows that if we just do the abdominal approach, you're probably going to be okay. If you're looking at cost effectiveness, you really don't want to do a vaginal approach. Now, another thing that we want to consider is the stress incontinence aspect. So a lot of people get urodynamics, and I just want to let any learners in the group know, make sure you push up that bulge when you do your urodynamics, because that's the way you determine if they're going to have incontinence after that prolapse is pushed up. I do a urodynamics, but in the office, you can actually do a simple cystometry. Dr. Howard Goldman, who is my director of my fellowship, loved this procedure, and it's cheap, it's easy. You can do it right in the office and get a good answer, because if they have occult stress incontinence, I'm going to put a sling in. Now, I think when I talk in a few minutes about bulking agents, that's really something we should be considering for these patients. Maybe bulking agents in abdominal sacrocolpopexy would be a good option for patients so they aren't overwhelmed with too many decisions. Now, what else about the procedure? Well, obviously surgeons have preferences. So the American Urogynecology Association basically did a survey, and they looked at what people do and why they do it. And there's a lot of variability. We find that the majority are doing these, robotically. Then they're also using suture instead of tacks. We in urology don't usually use tacks to tack up the mesh to the sacrum, but they do a lot in gynecology. And then they're also discussing, do they do the posterior repair at the same time? So, and then hysteropexy, that's something I just alluded to, the idea of saving the uterus when we do these procedures. And that's not offered. Specifically, our male surgeons don't offer that. Women tend to offer it more. So a lot goes into patient selection, and so you really have to come up with your gestalt or your approach to these patients. But I want to highlight a couple of efficiencies. I would like to say that I knew all of this when I started. That is not true. Everyone knows surgery is a process when you learn how to do things a little bit better. I think one of the biggest points, though, is if you're going to do robotic sacrocolpopexies, you need to have a good team. And so really, this is an interesting study looking at optimizing robotic surgery in the operating room, specifically about sacrocolpopexy. So they looked at the surgeon, they looked at the nurses, they looked at the first assist, and you would think, oh, this is dependent on the surgeon. Actually, it's the surgical technologists and the first assistants that are going to tell you how efficiently you can get this procedure done. Maybe that's not shocking to this room, but I thought it was certainly interesting. So this is actually a nice video that's kind of abbreviated, and I wanted to just show everyone. This is basically right now, this is Dr. Goldman's video, but you can see he's dissecting down, or we're dissecting down to the sacral promontory. And you can see the anatomy isn't always so obvious. And then when you start to see a little bit of bleeding, it's sometimes difficult to see the sacral promontory. Now, right now, this is a post-hysterectomy patient. So this is someone we're just doing the sacrocolpopexy on. He's dissecting, basically cutting the peritoneum, and then he's going to go and create that flap. He's basically using the retractor, and he's scraping up that tissue, kind of separating the tissue from the retractor. And then he has a separate incision for the posterior repair. And so you can see that pocket's always a little bit easier. The anterior dissection is a little bit more challenging. Here he's delivering that mesh. We tend to use the Restorel Y mesh. I think it's a little bit easier, but you can craft your own mesh, certainly. And he's delivering his sutures. These are actually absorbable sutures. These are PDSs that he's using to secure the mesh onto the vagina. And then this is probably the best part for the residents, tying knots on the mesh, but it's probably the most painful for me to watch as the surgeon, because there are a lot of knots that we're throwing to fix that mesh onto the vagina. And what we tend to use are sure cuts, and I'll show you a picture of them. They have little scissors that are in the crux or the end bit of the grasper, and you can actually cut the suture as you go. And these are just some more of those. This is actually, he is putting the sacral promontory sutures in. So he uses PDS as well, an absorbable suture, and he's basically skiving across that anterior longitudinal ligament. And he does 2 sutures. I do 2 sutures, but some people do 3 sutures. And you measure it. You basically are doing a lot of adjusting. You rely very heavily on your retraction. He's trimming up the mesh, and then he's going to close the peritoneum very soon. So the setup, very, very important. And everyone has maybe a different volume of assistance. Some people don't have someone doing a vaginal retraction for you, others do. So you have to be able to adjust based on your OR space. We can use a W, basically configuration of the ports, or you can do like the robotic prostatectomy, and that's the way that I do it, the same as if you were doing a robotic prostatectomy. I like to use the 8mm port for the assistance so I don't have to close the fascia. And then I always have the patient in very steep Trendelenburg, because this sometimes can be challenging with the bowels falling forward into your surgical field. I also like the 30-degree lens because you can see the promontory. You can adjust so that you can do the vaginal dissection. When I'm doing this, I have monopolars in my right, I have bipolars in my left, and then my third arm is a tenaculum if I'm doing a supracervical hysterectomy or a prograsp. So that's the robotic tenaculum. That is your friend. It's a wonderful tool when you're doing your supracervical hysterectomies. And these are the scissors that I was talking about, your grasping scissors. You have to be very careful, because if that suture flies right into that space, you're going to cut it by accident. So there's a learning curve, I would say. So from retractions, people use EEA sizers. That's probably what a lot of people do. You can also use a Breisky, which is actually really nice because it flattens the vagina and kind of aids in the dissection a little bit. In the States, we have some of these uterine manipulators. They're very expensive, but they're very nice tools because you can grasp the cervix and move the uterus to help with the dissection. And then they do have some reusable ones. And if you notice the curve, this is for someone that doesn't have a vaginal assistant. So they're actually having an assistant that's helping on the port, and then someone else who's, and they also have to use their other arm basically to do the vaginal retraction. So think about the setup. We have a lot of different tools to do the hysterectomy. We all use some sort of sealer or some sort of ligature device. I do not divide and ligate these independently. So a little bit about the dissection. As I said, start with a promontory. You're going to know if you need to stop. You're going to get into trouble and you're going to say, okay, we're done. Now, interestingly enough, the promontory is almost always when you get lost and you can't find it, it's 2 centimeters basically from where the ureter crosses the iliac. So if you go 2 centimeters medially, you're going to be at the sacral promontory. So this is a really nice landmark for you to use for the procedure. And then you can also, I don't know if you all use permanent suture, but some people use Gore-Tex. That's actually very helpful when you have a tough dissection, because you can actually color with a marker 1/2 of the suture to help when you're tying your knots if there's a lot of fat that keeps coming into the promontory. So that's also a nice trick. Now, if you don't think it looks right, take a step back and reevaluate the situation. So this is a picture from one of my colleagues. She's right where she should be. She's doing the sacral dissection, but there's a big lump there, and she had no idea what it was. She wasn't going to dig further. She said, this doesn't look right, and I'm done. Well, come to find out, there was a kidney. So certainly a very interesting case. And she got the CT after the procedure, and she did the right thing. She said, this doesn't look right. I'm not digging anymore. Remember, not cancer. We're going to do something else. And I think she did a uterosacral. So a little bit more about the vaginal dissection anteriorly. It really should be a bloodless plane. When you get into that detrusor muscle, that's when you can have some bleeding. And so that can make it also challenging if you haven't done your promontory dissection. That blood can kind of make the field obscured. So one thing that I've been thinking about doing and have been doing is when you make a vaginotomy, so my learners are sitting on the robot, they're doing the dissection, they're sweeping the bladder up. Oh no, now I can see the retractor, there's a hole in the vagina. What do we do? A lot of people just close it up, but I think really to prevent mesh erosions, you want to consider cutting a little hole out of the mesh so your mesh doesn't overlie that suture line. I think that may be where some of those extrusions have happened. And so far, it seems to work pretty well. Not the whole mesh, obviously, just a piece that's overlying that vaginotomy. Another thing that's really nice to speed up the process, rather than tying 5,000 knots when you're fixing the anterior and the posterior mesh, is doing a V-lock suture. So those are those sutures that kind of grab, so you can do a stratus fix or a V-lock suture, and you just run it back and forth across the mesh. It saves a whole lot of time. And the other thing that we like to do as robotic surgeons is we like to break the suture. You can almost do it with every type of suture. So just use your grasper and just pop it, and it'll actually, you don't have to have your assistant go in and out to cut the suture the whole time. As I highlighted from the video, the post-hysterectomy dissection is a little bit different. We don't actually take off the peritoneum from the actual cuff because that's where a lot of scarring is, and that's where you're going to make some vaginotomies. So try to just make a separate incision over the anterior plane and then the posterior plane, and that works very nicely. So suture. I talked about the V-lock. It's a really great tool to speed things up. But the other question is, does it matter if you use a permanent or an absorbable suture? So we've really moved away from using permanent sutures, but some people like this Gore-Tex suture, and it is a great suture. Well, the literature shows you should do whatever you want. There's really not a difference if you use absorbable suture or you use permanent suture. I like PDS for my sacral bites and just to secure the mesh on before we use the V-lock. So mesh, does the type of mesh matter? Well, I would say probably not as much as we would like to think it matters. So you can fashion your own out of a sheet of mesh, and I've certainly done that. Definitely for my complex patients, I've had to do that. We use the Restorel mesh most commonly because you can see it's already pre-made. It's really nice. You just deliver it in. Now, does it matter if it's lightweight or ultra lightweight? I really don't think it does. Basically, you're not going to have prolapse recurrence, and you're not going to have a lot of symptoms. We've been using more of the ultralight just because it is a little bit lighter and may be less rigid in the vaginal tissues. So a little bit more about the mesh. A couple of tricks. You can pre-measure. So if you've got your robotic bipolar, that's 2 centimeters. So you can basically measure out your dissection on the anterior wall and the posterior wall. So you can pre-cut your mesh, and then you put it in a nice little cigarette, kind of like Dr. Goldman did. Got a nice little cigarette, you pop it through that port, and then you can just unfurl it. I just put a Vicryl very loosely. Don't tie it tight. You want it really loose so you cut it and it rolls out, and that saves a little bit of time. So we talked about the supracervical hysterectomy. I actually think this is easier for your sacrocolpopexy because after you do your supracervical, those planes just peel on back. So actually the vaginal dissection is a lot easier. I use the tenaculum in the left arm, monopolars in the right, and then if you do want to use an endo catch bag, you will have to change your port, so it'll have to be 10 millimeters just so that you can get the material in. And then again, we want to do the sacral dissection first because the hysterectomy can definitely be bloody. So uterine preservation, this is something that's newer for us in the States. And really, you aren't going to use the Y mesh. So you've probably seen diagrams where they have giant sheets of mesh that are around the uterus. I think this is actually a really nice approach. You have to fashion it out of one of the sheets of mesh, and because it has to be longer, basically, and you wrap it around the cervix. And then you can tack it to the lateral aspects of the vagina to give it an extra little bit of pull. And this is a really nice approach for anyone that wants to save their uterus. The other benefit is I do a lot of the congenital patients. So bladder exstrophy patients are predisposed after their closure to have prolapse. A lot of them want to have babies, and they're going to have a C-section anyway because they have a continent catheterizable channel. So this is a really nice way to help them with their prolapse, allow them to get pregnant, and then not have a lot of side effects. So I think that this is a great approach, and it's worked really well so far. Now, we all are very fearful of the complications. Prolapse recurrence, of course, is a fear. Sacrocolpopexy, that may be a little bit less. We're worried about pain. I'm certainly worried about mesh complications. It's very litigious in the States right now, so we spend a lot of time counseling patients. Now, another thing that has come up is osteomyelitis, and this is a very challenging situation. And, I don't know the perfect way to really prevent that, except as you're passing your suture on the sacral promontory, you really want to just skive through that anterior longitudinal ligament. If you go deep, you could get in the disc space if you're not in the right spot, and that's when this can happen. And it is devastating for patients. It's devastating for patients. So what about postoperatively? Well, we are doing actually a lot of same-day discharges on this patient population. I know it may be a little bit different here where patients like to be in the hospital. We kind of set it up as an expectation up front. You're going to have your surgery and then you're likely going home. But if there's a problem or you have nausea, then we'll keep you overnight. And setting it up that way has allowed us to really kind of operationalize this for a lot of our prolapse cases. Uterosacrals, vaginal hysterectomies, everything that we're doing, we're actually doing same-day discharge. And it's really been great. Well, that is a brief overview of robotic sacrocolpopexy. I'm staying on time because I know I'm the last stop before our lunch, but I want to have a few points. Patient selection and preference is key. So you got to have in your mind who you're going to offer this to and how you're going to do the procedure. Make sure to talk to your patients about these very important aspects. I didn't used to think about it when I was a fellow, but now I really have to think about it because it's started to change. And then have a backup plan. This, with the robotic procedure, you can run into issues. And the problem is if you say, okay, I'm going to convert to open, you're going to have a big incision. This is a big incision. This isn't a small incision. And so usually I have a vaginal approach in the back of my mind to help with this. And then it is okay to always back out. If you don't feel comfortable, always do the right thing, because fundamentally you want to make your patient's quality of life better and you don't want to make it worse, right? It's different than cancer. This is quality of life. And then really spending time to develop your team. I wish I could say I had the same group of people every time I sat on the robot. That is not the case. But if you have the ability to do so, definitely spend time, because they're with you, they make it more efficient, and they impact the timing of surgery so much more than even the surgeon does. And then same-day discharge. I know it may be challenging, but it's something to be thinking about, and that's what we're kind of moving on in the States for a lot of our procedures. And I want to send a special thanks to Dr. Howard Goldman for his video, and then one of my wonderful colleagues who sent me the pictures of the pelvic kidney.